Srinivas wanted us to do a case of acute coronary syndrome, and as Sir also showed, the vulnerable plaque erosion and an ulcerated plaque. But it's a challenge sometimes to get these cases, and I'm so glad you showed those cases because sometimes less is better, as shown by the erosion data as well. Because sometimes you can get away without stenting in most of these cases. We had planned this. Hi, good morning, everybody. I am first of all thankful to Dr. Srinivas and the entire team at TCT Hyderabad for giving us this opportunity. I am Dr. Aditya Kapoor. I have with me two of our very accomplished interventional cardiologists, Dr. Roopali and Dr. Ankit Sahu, and we have Dr. Arpita here, Mr. Shiv Dayal, Mr. DK, and Ashwini from the Abbott team. So this was the case. He was a 56-year-old guy who had had chronic stable angina for last 5 years, and he had some recent worsening for 1 month, and the symptoms had escalated over the last 2 weeks. He was a tobacco chewer, the vitals were stable, and clinically no significant findings. So we took him up as a acute on chronic recent worsening case, hoping that we will get some angiographic and some good OCT findings. And I'll just, the next slide, the small videos will have Ankit and Rupali running through the ECG findings and the angiographic findings.
So ECG have some ST coving, mild ST coving in V2 and some ST depressions in V3, V4. Otherwise, it's okay. Echo is normal. There is no regional wall motion abnormality. EF is within normal limits. Lab parameters are okay. Creatinine is fine. We have the angiography.
See, this was done through radial route, and we have a left main which looks normal, and LCX is a big vessel, but it's for sure looks free of significant disease. But if you see the epicaudal view, the LAD was having an osteoproximal critical lesion, which was causing a decreased flow in the antegrade flow in the LAD. It was like a TME2 flow or TME1 flow in distal part, and which was confirmed in other views also. Can we have the next slide, please? So this was the areocranial view, which showed a critical LAD, which was causing a TME0 flow, and which was confirmed in the different views. There was a classical osteoproximal lesion, which according to the ECG also we suspected that these people are dealing with a critical LAD lesion. And if you see his RCA was also free of any significant disease, and there was a distal filling of LAD, which was a mild retrograde collaterals, if you can see, which was partially filling the LAD, not very good collateral.
So, and this was the LV angiogram as Ankit mentioned on the echo. The echo was normal and so was the LV angiogram. So we have a patient who had chronic stable angina, recent worsening, and this was the angiographic picture. So can you get the angio on the? We took a right radial axis. We have the rad pad in place, and we have a EBU 3.5 guide. And the angiogram was actually done outside some time ago, about a week ago. So we just did some check shots with the guide. Angio on the screen, the angio shots. Yeah.
Yeah.
So this is the areocranial, and if you go to the next angio, please. So there seems to be some leader there. So in your opinion, I mean, we have taken the normal EBU guide. What wire should we start with? What would your choice be?
I think it's a recent
So we took a normal workhorse wire because it looked like a
sensor
obvious
which is
leader is
having a
there.
critical stenosis with some, I think, thrombotic occlusion because it's slow flow across the LAD. So we can go ahead with a normal workhorse wire.
Yeah.
And if you can see, the LAD filling is definitely better what it was prior to it.
Yeah. Can we up the mag a bit?
Yes, sir.
Somebody give me a test.
Yes, I think we have entered, sir. Yes, sir.
Is in the diagonal, and now we are in the LED, and can I just see? Is there any forward flow? I doubt.
I think we post.
Can you get the angio on the? So again, we had some short discussion. What would you now do, a thromboaspiration or directly go to a balloon to create a channel and then image? Because we were unsure whether we'll be able to get the OCT catheter through and get some any good images without creating a channel. So thromboaspiration versus directly going to balloon dilatation or creating a channel. So we opted to initially pre-dilate with a 2 ml balloon. So maybe you and Rupali can also run us through the fact that if somebody just for discussion sakes wants to say that, okay, I just want to do a thromboaspiration at this point of time, so how sort of relevant would that be, or shall we straight away, as we are doing, we are going ahead with the balloon?
Sir, actually, thromboaspiration routine practice, I think we still do, now we're going back to it, like we don't have a much data, and this has shown that routine thromboaspiration has led to more complications rather than benefit. So since we didn't find any grade 4 thrombus in this case, it was just a stenosis critical area. So we can just do a small balloon dilatation and
Because many a time we do thromboaspiration, but obviously when you have a huge thrombus burden, here we thought, we should again just do a small balloon and try to create a channel and then do the image. So we took a 2 mm
circumflex
balloon.
is right there. So
I think it
let the
slipped.
balloon slip a
Yeah,
bit, I guess.
osteofibrosing
Because
Retest it.
we don't
Yeah.
want to do much
Yeah,
high
yeah.
pressure balloon dilatation because we want to see the plaque morphology in this case. So going very high pressure, we might call dissection, which will be little,
It
it's
just
slipping.
slips a
It's
bit.
slipping, sir. Yeah.
Seems to have created some channel.
Record. Fluoro record.
Because this was a challenge we were getting. The balloon kept slipping, and we thought that there could be some, could be some fibrotic plaque, because sometimes due to the
So which
thrombus
imaging,
also,
Ankit,
or
you
due to
want
the
to go ahead with?
fibrotic plaque also, the balloon might, shift a bit. So we didn't want to do any high pressure dilatation. We didn't want to modify the plaque before we imaged, but this was the challenge we were having. So we created a channel with a 2 mm balloon,
So which imaging, Ankit, you want
and
to go ahead with? Is IVUS, OCT, or in these
Ideally, I would go.
ACS
I would like to go
case?
ahead with OCT because plaque morphology is a prime concern. So how to modify the plaque, and if thrombus, we are also suspecting thrombus. So
Hanji.
OCT probably.
so we opted to go for an OCT, obviously, because there was an osteal disease, there was a suspicion of underlying thrombus, so we opted for an OCT, and these are the initial OCT runs. Not great images because the channel with the 2 mm balloon was not great, but this is what we got. So predominantly we felt it's a fibrofatty plaque, there was some lipidic areas, necrotic core was there, there was no obvious calcium, and there was some definite fibrous plaque near the ostium of the LAD as well, and there was significant luminal obliteration of the initial most critical part. The left circumflex and the left main appeared free of disease, so that was a bit of a relief. And so as I said, there was a mixed fibrofatty and lipidic necrotic plaque, and the LAD ostium, the area was 2.24. The left main looked free of significant disease. But at this point of time, we did not notice any significant thrombus or anything, which made us suspect that it was a recent occlusion. We could not find any thrombus. So what next? Should we use a bigger balloon? Should we use a non-compliant balloon because the balloon was slipping and there was a different fibrofatty core to the plaque, or a cutting balloon? So these were the three options, and we opted to go for the cutting balloon first because we felt that the fibrofatty, the arc was nearly 360-degree in the OCT. So we took a 2.5 mm, 2.5 10 millimeter Wolverine cutting balloon and slow inflation deflation as per the protocol, and we dilated near the ostium. And this balloon obviously did not slip, and we could get good anchorage with the balloon. And so we felt that using a cutting balloon was not a bad choice up front rather than go for an oversize or an NC balloon. And after the cutting balloon, we could get reasonably good flows. So the flow remarkably improved after the cutting balloon, and then we did an OCT, and although we know that now we have sort of distorted the original morphology by the cutting balloon, but this is what we got after the cutting balloon OCT, the OCT images. So there's a significant luminal gain. The cuts were beautifully demonstrated, and if you see over here, there is a significant luminal gain, and this point of time, this is what we were wondering whether this is a thrombus or, but the point is that we are not already cut with the cutting balloon, so this could very well be a dissection flap produced by the cutting balloon. So this was the image after the cutting balloon, and we could see some luminal protrusion initially there was some doubt that could be a thrombus, but again we disregarded that possibility because it was not seen in the original run. Few microchannels were also clearly visible, suggesting the acuteness of the plaque. So we decided no further plaque modification is needed at this point of time, and now we should straightaway proceed with the stent. The sizing of the distal diameter was around 3.9. So now again the challenge was a careful ostial LED placement or crossover from left main to LED. So, we discussed, debated, and we thought that since the left main was clear, the circumflex ostium was clear, the angle is pretty good, we can get away with an ostial placement of the stent. So we took a 428 stent. This was an Alpine, if I remember correctly, 428, and we obviously confirmed it in multiple views. Because the challenge over here is to place it very carefully at the ostium. Although the good thing is the left main is pretty roomy, the circumflex angle is encouraging. So obviously taking multiple views. Confirmed it in a LAO caudal as well, and then again came back to AP caudal. Fairly comfortable over here, so we deployed the stent at this point of time, and this was the post-stent angiogram. Circumflex looked pretty good over here, and we did a post-PCI LAD to left main OCT run in the distal half, and if you see over here the expansion is around 80%, more than 80%, which is pretty good. There is no malapposition distally. There was no tissue prolapse, no edge dissection. So we took obviously another run for proximal assessment because it's falling short. So over here, if you see, there was some malapposition noted in the proximal part of the stent. So malapposition was noted in the proximal part, and although there was some obvious luminal gain, the left main area was pretty good. So we dilated initially with a 4.512 NC at 8 atmospheres. We did it at 8 and then did a OCT run, and the MSA over here was 8.19. Again, there was some malapposition again noted at 8 atmospheres. So we obviously went ahead and did it finally with 16, and finally we could get another OCT run here somewhere. Yeah. So at 16, then we did this OCT run. There was no malapposition or edge dissection finally. This videos doesn't seem to work. So the final was done with a 4.516 in the proximal part of the LAD, and we could get a good result. The left main was fine, the left circumflex ostium was fine, and so to conclude with, this was a case of recent exacerbation of chronic stable angina, near total LAD occlusion, easy wire passage, initial 212 balloon slippage. So we opted to use a cutting balloon, did an OCT, and we found a fibrotic plaque, did not find any thrombus or any plaque erosion. It was a predominantly lipidic plaque, necrotic areas. The left main was free of disease, and as I said, we prepared the bed with a cutting balloon, image guided ostial LED placement, and a final good result. So that's it. Thank you.